All right, guys, we're going to go ahead and finish up the chapter on the lower extremity. This lecture is really going to focus on the knee joint and all of the possible injuries and the ligaments and cartilage of the knee joint. At the very end, I do have a couple of pictures of the ankle. I'm just going through the numerous ligaments that are present in the ankle, but we're not going to focus on ankle injuries in the lecture. We have just about an hour's worth of lecture today, and I think I will fill that up with the knee, and then we'll cut it at that. We'll start by talking about the collateral ligaments. When we look at the knee, there are four major ligaments, large ligaments that are present in the knee. Two are collateral ligaments, two are cruciate ligaments, and then we have a couple smaller ligaments like the meniscofemoral ligaments that attach the meniscus, the cartilage, to the femur. So we're going to start with the collateral ligaments. So there are two collateral ligaments. Collateral meaning they're outside the joint capsule. So these are not deeper within the joint capsule. The ligaments are actually outside the joint capsule. So when we look at this picture right here, you see up top the femur. And remember, the femur has a lateral condyle and a medial condyle. And then this is the patellar surface where the patella would sit. The inferior bones you see are the tibia and the fibula. The tibia also has the condyles. So there's a medial condyle here and a lateral condyle here. I know medial versus lateral because of the position of the tibia and fibula. The tibia right here, remember, is more medially located, and the fibula is more laterally located, right? Fibula lateral. So that's telling me, which of the condyles is medial and which of the condyles is lateral. The collateral ligaments are going to attach the femur up top down to the tibia or to the fibula. So here on the medial side, right here inside that circle is the medial collateral ligament. Medial collateral ligament. It's also called the tibial collateral ligament. Tibial because it attaches to the tibia, medial because it's medially located. On the other side, we have the lateral collateral ligament, or it's also called fibular collateral ligament because it attaches to the fibula. So you can see here it's attaching to the lateral condyle of the femur, and then it comes down in here and attaches to the fibula. The biceps femoris tendon comes just outside that, so that's that little white that you see cut right there is the biceps femoris tendon. Right, so tibial collateral ligament is extending from the medial condyle of the femur down to the tibia. The lateral collateral ligament is attaching to the lateral condyle of the femur and then down to the fibula inferiorly. Again, these are collateral ligaments, so they're outside the joint capsule. These mainly stabilize like the sideways angulations of the knee joint and of the tibia. So they try and keep the tibia, on the femur like this, so that the tibia doesn't bend outward in this direction, or so that the tibia doesn't bend inward in this direction, which we'll talk about. Okay, so we're going to talk through numerous different knee joint injuries. Knee joint injuries are typically relegated to the ligaments and or the cartilage in the knee. So either sprained ligaments or torn cartilage in the knee joint. We're going to start by talking about MCL injuries, and then we'll do LCL injuries, and then we'll move on to the cruciate ligaments inside the knee. So MCL ligament injuries or medial collateral ligament injuries are relatively common ligament sprains and tears. The medial collateral ligament, or again, remember it's called tibial collateral ligament, connects the femur to the tibia on the medial side of the knee outside of the joint capsule. And external to the joint capsule, hence it's called collateral. This prevents a lateral angulation of the knee lateral angulation, or this is called valgus stretch. You guys have seen the terms varus and valgus, right? We looked at coxa vara, coxa valga. Varus and valgus are just general terms. Coxa means we're referring to the hip when we're talking about it, but we can also refer to angulations of the knee. Valga is a term that refers to an outward angulation of the distal part of the limb. So like if we're looking at the knee, you have your femur, and then you have your tibia and your fibula out here. Valgus stress is an outward angulation. So instead of being straight like this, if the knee was pulled in this direction, right? So like the foot is pulled outward, that would be valgus stress. So like, again, lateral angulation. So the leg is angled laterally. The medial collateral ligament helps to prevent that. A medial collateral ligament is right here, right? So it helps to hold this side of the leg strong so that it doesn't pull too far in the other direction. Because if you pull on it, right, if you pull the tibia this way, you're going to be pulling on that ligament, and it only allows so much give. The medial collateral ligament is also firmly attached to the medial meniscus. The medial meniscus is the cartilage pad that's right here. There are two cartilage pads that are present in the knee. The medial meniscus is here between the medial condyle of the femur and the tibia. The lateral meniscus is on the other side, or on the lateral side, between the lateral condyle of the femur and lateral condyle of the tibia. So as this medial collateral ligament passes through here, there's like the inner layer of it is firmly connected to the medial meniscus. Because of this, medial collateral ligament tears are frequently associated with tears of the medial meniscus. We do see tears of other ligaments as well, in kind of larger, more high energy knee injuries. Medial collateral ligament injuries are common in athletes who have sudden changes in direction and speed. So soccer, tennis, skiing, etc. We also see these in contact sports like football. They can be caused by a blow to the lateral knee while the leg is extended. So while the leg is straight and extended, if there's a hard blow to the lateral knee, so a hard blow in this direction, you can see how that would push on the ligament and put stress on the ligament. Because when you have a hard blow in that direction, you're forcing the angle against that ligament, so you can tear or sprain that ligament. Again, also excessive lateral twisting of the flexed knee. We mentioned that other ligaments are commonly torn at the same time, especially the medial meniscus, because the medial meniscus is, again, attached to the medial collateral ligament. So if you're tearing this midsection of the ligament, then you can actually tear that part of the meniscus where it's attached to it. Common in sports, really all of these ligament injuries are common in athletes. When evaluating somebody for a tear or damage to the medial collateral ligament, it's going to involve, of course, a full comprehensive knee exam, which is a pretty comprehensive exam. But one of the tests that you can perform to evaluate the medial collateral ligament is the Valgus stress test. Remember, we said that the MCL protects against valgus stress. So we can put valgus stress on the knee and see if it can resist that stress or not. I'll show you a picture of the valgus stress test in just a second. Presentation of a patient with MCL damage. Patient presents with pain, swelling, especially if it's been a little bit of time since the injury. When it comes to all of these knee injuries, it's best to examine the patient as soon as possible. If there's been considerable, if there's been time that's passed since the injury, swelling occurs, And the more swelling there is, the more pain there is, so the more resistant the patient's going to be to allowing you to manipulate the knee. Also, the swelling kind of obscures all of the structures, so it makes it harder for you to palpate all of the structures in the knee if there's a lot of edema present. But patients will present with pain, swelling, joint instability. In other words, the joint won't be able to resist that valgus stress, and it's more movable or mobile than it would usually be. Active range of motion may be limited. In other words, when you ask the patient to flex and extend their knee, that range of motion might be limited more so than their other unaffected knee. But passive range of motion usually is not limited. So if you have the patient completely relaxed and you move their knee for them, you should be able to get that full range of motion from their knee, unless there are other structures that are involved. As always, when we're talking about doing one of these tests on the knee or comparing range of motion or looking at range of motion on the knee, always, always, always compare affected knee to the other knee, or to the unaffected knee. There's a lot of variability between people. My normal range of motion might be different than your normal range of motion. The laxity in my knee, like the amount of movement that's allowed in my knee, might be different than the amount of movement that's allowed in your knee. So, the physician might try and manipulate or move the knee around and think that it moves quite a bit, but that might be perfectly normal for you. There might not be any injuries to the ligaments at all. You just might have a very lax knee, a knee that allows a lot of movement. You've got relatively stretchy ligaments. So the way that you can take account for individual differences in anatomy is by comparing the injured knee to the uninjured knee. And then say, okay, is there more movement allowed in this knee versus their other knee? That gives you kind of a nice standard to go against. Okay, so again, valgus means outward angulation of the distal segment. So outward angulation is like, in this case, we're talking about the knee joint. So imagine the foot is moving out laterally, right? So the foot moves outward laterally. That's a valgus movement or valgus stress. So the MCL, right, the medial collateral ligament, provides a valgus stabilization. It helps us stabilize the knee against this valgus movement. So in order to test the integrity of the MCL to see if it's doing its job, we can do the Valgus test. Excuse me, here in A, this is showing us the Valgus test, again, to test the integrity of the medial collateral ligament. So you can see the knee is being pushed inward, right? So the knee is being stabilized more kind of inward, while the foot and ankle are being angulated more outward laterally. So you have to stabilize the knee here, because otherwise, if you just pull out the foot, you're going to move the whole leg. You're going to be moving the hip. We're not trying to look at the hip. We want the knee to be maintaining this inward pressure while the foot maintains the outward pressure. And see if you can angle this leg like this, right? The knee's not supposed to be bending sideways, right? The knee is a hinged joint. For the most part, it should only allow flexion and extension like this. It should not be going, sideways, abduction and adduction. So this is more of an abduction, right? You're testing to see if this knee can abduct, if you can bend it out sideways. So again, the distal part of the leg is pushed more laterally, and this tests the ability of the MCL, right? The MCL is this ligament that's right over here. This tests the ability of the MCL to prevent that. Can it prevent that angulation of the knee or not? Again, it's important to always compare this affected knee to the other knee and see, is there more laxity? If there is laxity, if you can abduct that knee considerably more than the other knee, then that's a positive valgus stress test. which is a sign that there is MCL damage. So that was the medial collateral ligament. The lateral collateral ligament we saw on the other side of the knee. So the lateral collateral ligament, or it's also referred to as the fibular collateral ligament, attaches the lateral condyle of the femur to the proximal aspect of the fibula, or the head of the fibula. So again, it's outside of the joint capsule or external to the joint capsule on the lateral side of the knee. Now this prevents medial angulation of the knee. So the opposite. If this is my femur, right, and my tibia, and then my fibula is out here, I'm talking about the lateral collateral ligament. So I'm talking about my ligament right here. And this is preventing varus stress. This is preventing my leg from angling inward like this, right? So it prevents the leg from varus stress, right? Inward angulation of the distal part. The lateral collateral ligament is part of the kind of posterolateral structures of the knee, and this provides most of the, or a lot of, posterolateral support of the knee. LCL tears are rarely does a patient have just injury to the LCL, the lateral collateral ligament. One of the reasons for this is the way that the LCL is torn is from a blow to the medial knee. So if you're thinking about your knees, okay, if we tear the MCL, it happens from a blow from the outside. Okay, that's pretty common. If something's going to come at you, it's normally going to come at you from the outside, from the lateral side. Tearing the LCL usually happens because of a blow from the medial aspect of the leg, the inside. It's more odd, if you will, for something to blow your leg from the inside, right? From the inside of you. Things normally come at you from the outside, not from the medial aspect. So this blow to the medial aspect of the knee is a little bit more rare. So LCL tears are a little bit more rare. Usually when the LCL is torn, it's because of some bigger high energy blow that results in a multi-ligament knee injury. So some high energy force that involves hyperextension of the knee combined with a blow to the medial knee that ends up tearing multiple different structures back in that kind of posterolateral segment of the knee. Other structures that are commonly involved are the posterolateral soft tissue, the posterolateral corner of the knee, all of the soft tissue that's back there, the posterior cruciate ligament, or PCL, the anterior cruciate ligament, or ACL, and ortholateral meniscus. So this is usually a big high energy blow that's got a lot of damage to the knee. Very rarely just the LCL. Common presentation for LCL tears are football players who are tackled, and when they were tackled, they sustained a blow to the medial knee while their foot was planted and leg was extended. So like running, for example, if they're running and that foot is planted, leg is straight, and they get tackled from the medial aspect, that's a common, common kind of indication that there might be LCL damage. Pain is again also usually in the lateral or posterolateral aspect of the knee, whereas a MCL tear would be pain localized more to the medial aspect of the knee. Non-contact injuries can occur. The non-contact injuries are usually when there's a really huge weight load that's put on the knee. So we see it in weightlifters who have poor lateral support of the knee with the musculature. So if there's not enough muscle support of the lateral knee and they have a, are deadlifting, for example, or squatting a huge weight load, that weight itself can blow out the ligaments. Again, symptoms kind of similar to what we saw with MCL in that we've got pain, we've got swelling, a sense of knee instability. If the meniscus is involved, and this is the same for the MCL, if the meniscus is involved, if there's a meniscal tear, then there's a locking or catching in the knee. So the meniscus, the cartilage padding between the knee, between the femur and the tibia, provides a nice smooth surface for the knee to do this. If there's a tear in that meniscus, it's not smooth anymore, and you can have like a little piece that's kind of sticking up, and then as the knee tries to move, it gets stuck. It's like something getting stuck in the gear. So the patient might not be able to smoothly move their leg all the way. It might get to a point and get stuck. They might not be able to lock their knee, right? They might be able to straighten it to a point, but they can't lock it because that cartilage is not smooth anymore. Again, that's if the meniscus is involved, which we'll talk about meniscal tears at the very end of the lecture. And then also the knee giving out under stress or weight, so not being able to hold up to the weight of the body when you walk. So we said that the LCL, right, the lateral collateral ligament, provides a barrier to varus instability. Right? So when we're evaluating the LCL, we do it over here in this picture B. We provide or we perform the varus stress test. LCL provides a barrier to varus stress. So if there's an LCL tear, it's not going to be able to do this, and we'll be able to manipulate the knee in a varus motion more so than the unaffected leg. So varus, remember, means an inward angulation of the distal leg. So not laterally, now it's going inward. So this is like adduction, the movement adduction. The knee should not adduct, right? The knee, you should not be able to move the knee like this, right? You can flex and extend. You should not be able to move it inward towards the midline. In order to do the varus stress test, the knee is, oh, sorry, that's not inward. This way would be inward, okay? So X that. This movement out here would be abduction. We're talking about adduction, so that would be movement of the knee in this way. I wasn't paying attention to which side was the midline. So in order to test this, the hand is put on the knee and the knee is pushed almost outward, right? You make sure that the knee doesn't move with the ankle. And then the foot and ankle are pulled inward towards the midline of the body. If you can push the foot in towards the midline of the body and have that adduction movement, then that's a sign that the lateral collateral ligament is not able to provide that varus stress stabilization, right? The LCL is right over here, and it should prevent that movement of the leg inward like this at the knee. So a positive sign is more movement, that varus movement, where the foot moves inward. Okay, so moving on to the cruciate ligaments. We just talked about collateral ligaments that are outside the joint capsule. We also have cruciate ligaments that are inside the joint capsule. The two largest, most important ligaments inside the joint capsule are the ACL and the PCL, the anterior cruciate ligament and the posterior cruciate ligament. So the ACL, anterior cruciate ligament, starts on the medial part of the lateral femoral condyle. So it goes from the femoral condyle in the femur, the bottom part of the femur, and then it extends kind of down in like an anteromedial fashion. So it heads kind of down towards the middle and front of the to the like middle front of the knee, and then it connects to the tibia, in like the front of the tibia between the two tibial condyles. So here, let me draw the femur, the tibia, and then we'll do the fibula over here. So it starts at the fibula on the inside or kind of medial side of the lateral condyle of the femur. And then it extends downward towards the front and center of the knee. And it attaches here on the tibia between the two tibial condyles. It's the anterior cruciate ligament because it is in front of the PCL. The posterior cruciate ligament will kind of attach and go back behind this, back towards like the back of the knee, like that behind it, kind of Y-shaped. The anterior cruciate ligament acts as a pivot point for rotary movements, and it prevents too much anterior movement of the tibia. So it makes sure that the tibia does not slide forward further than the femur. ACL rupture, ACL tears are the most common ligament injuries of the knee. So ACL tears are very, very common, especially in sports. Any sudden pivoting or cutting movement while the foot is planted can tear the ACL, especially if there's like if the person's, when they're zigzagging really fast, you run really, really quick, plant the foot, like decelerate really fast and turn. The foot gets stuck planted where it is, but the rest of the body turns. So the femur twists on the tibia. And that's the pivot point. It allows some turning, but not much. So if you over pivot, you're going to tear that ACL. These are usually non-contact athletic injuries. So again, notice there was nothing about a blow. It's just the body, the person's body themselves. They're moving, they happen to plant their foot and the foot doesn't slide. It doesn't pivot with them. So the tibia holds still while the femur twists, and that tears the ligament. It can occur because of blows. Like sometimes you'll see it in football or in soccer. Someone is slide tackling somebody else, and it happens. But most frequently it's non-contact. We do also see these in high energy motor vehicle accidents. And in terms of high energy motor vehicle accidents, these are really highly missed. They're often missed in MVAs because it's not something you would think of. But we see them in soccer, football, basketball, especially women's basketball. And then in alpine skiing. So there's differences in the sexes in different sports. They're not common in men's basketball. They're very common in women's basketball. We don't see them much in recreational skiing, but we see it in alpine skiing. So there's some variability there. Gymnasts, it's very, very common in gymnasts as well. You can imagine all of the, like the twisting and all the force when someone lands, that would be common. When we see a patient with an ACL rupture, the tibia slides anteriorly on the femur. So normally the condyles should match up with each other. And remember, we said that the ACL keeps the tibia from moving forward too much. But if there's a tear, it can't do that, and the tibia slides forward like this. So if this is my femur, on the bottom is the tibia. Instead of being lined up, the tibia slides forward. That's called an anterior drawer sign. Anterior drawer sign. Think of it like a drawer slides in and out, right? So the drawer is just pulled towards the front. The drawer is pulled forward. Anterior drawer sign. So this is the knee bent. When the knee is straight, the femur kind of goes forward like this, and you can't see the ACL. It's deep within the knee, so you kind of have to pull the femur back like that in order to see it. So that's what you're looking at. Like when the knee is straight, the femur would go up like this, but it's been pulled back, so you're kind of looking at like the bottom of the femur. This is the ACL right here. Again, looking at the femur, this is the lateral condyle, right? The other one, medial condyle. We said that the ACL attaches to the inside or medial aspect of the lateral condyle. It stretches down, towards the middle and front of the knee, and then it attaches to the tibia between the tibial condyles, which the condyles of the tibia are here and here. What you see poking out behind that is the PCL. So like in red over here, this is the posterior cruciate ligament, and it's going to go towards the back of the knee. ACL injuries are really common, so we're going to go into a little bit more detail, and we'll talk about two different tests that you do during a comprehensive knee exam when evaluating for ACL injuries. Lachman's test is when the knee is placed in 30 degrees of flexion. So the patient lies on their back, they lie down prone, they lie down supine on their back, and the knee is flexed in a 30 degrees of flexion. And you stabilize the distal femur, right? So the femur is held in place, the thighs held in place, and you pull the proximal tibia anteriorly. So you can see him here, he's grabbing the tibia, right? Here's the tibia. Up here, you can't really see his hand, but he's holding the femur in place, holding the thigh in place, grabbing onto the tibia and pulling it forward, pulling it anteriorly. The ACL should not allow that, right? The ACL should hold the tibia so that you can't pull it forward too much. If there's increased anterior translation, in other words, if the tibia moves forward towards the front more, that suggests ACL injury. Remember, you're always comparing this with the uninjured knee. So different knees have different laxities or flexibilities. So you need to do this in the uninjured knee and then do this on the injured knee. If the injured knee has more laxity, you can pull that knee forward more. That's a that's a sign that there's damage to the ACL or anterior cruciate ligament. Anterior drawer sign, really it's kind of testing the same thing, testing that if the tibia will be pulled anteriorly more. It's just kind of a different way of doing it. So anterior drawer sign, again, you've got the patient lying down supine, the knee is flexed at 90 degrees. So you have to stabilize the bottom of the foot here. So frequently, you can, like the clinician will sit on the foot. You can't see him doing this, but he is, like his legs are right here, and he's actually sitting on her foot to stabilize it. And the tibia is grabbed, the proximal tibia, the top of the tibia is grabbed with both hands, and it's pulled towards the front. Again, you're checking to see if that tibia will slide anteriorly or not, right? Which we call anterior drawer sign. So if the affected leg or the injured leg slides forward more than the uninjured leg, this is positive, right? A positive anterior drawer sign. Again, they're really testing the same thing. It's just in one, you're stabilizing the femur and pulling. In the other, though, just a different way of doing it. Moving on to the posterior cruciate ligament, or the PCL. The posterior cruciate ligament, or PCL, is the strongest ligament that we have in the knee. It extends from the femur to the tibia, posterior to the ACL, or posterior to the anterior cruciate ligament. It actually has two different bands of collagen in it. It has the anterolateral bundle and the posteromedial bundle. So there, again, that's why I said it's kind of Y-shaped. it starts towards the same place, but then it kind of winds down like that as it goes towards the back. The PCL prevents posterior movement of the tibia. Both the ACL and PCL do provide other stabilization to the knee as well. Like they do help to prevent some of the varus and valgus movements. They do provide other stabilization as well. It's just like the thing that you can attribute to the PCL is preventing posterior movement of the tibia. For the ACL, prevents anterior movement of the tibia. PCL rupture occurs when the patient lands on the tibial tuberosity with the knee flexed. The tibial tuberosity is, remember, on the anterior proximal part of the tibia, just under the knee. Like if you palpate the knee, you can palpate where the patella is, the kneecap, and then just go down a little bit from that and you'll feel a little bulge on the tibia, a little part of the tibia that sticks out. That's the tibial tuberosity. So when the knee is flexed, a person falls on their knee really hard. Like if they fall down, like if the knee is bent like this, right? And they fall really hard right here. That's where the tibial tuberosity is. That can end up pushing the tibia backwards. This is common in contact sports like football, where people get tackled and forcefully pushed down onto the ground. Typically, if the posterior cruciate ligament ruptures, there are other ligaments that also get ruptured, like the MCL or the LCL. Again, 95% of these injuries occur with other ligament injuries. So it is very rare to tear just the posterior cruciate ligament. And this is because it's so strong. It is the strongest ligament. So if it's getting torn, you can believe like the knee has been pulled so hard that other things are getting torn as well. When the PCL is torn, the tibia moves back too far. So when it's torn, we see the tibia slides posteriorly under the femur. We call this the posterior drawer sign. Posterior drawer sign, right? Like a drawer slides, but now the drawer is sliding backwards, right? The tibia down here is sliding towards the back instead of towards the front. So the tibia slides forward, that's anterior drawer sign. That happens when the ACL is torn. The tibia sliding backwards, that is posterior drawer sign. That happens when the posterior cruciate ligament, or the PCL, is torn. Most common reconstruction involves repair of the anterolateral bundle only. So usually we're looking at the anterolateral bundle, not the posteromedial bundle. So looking at this, you can see this is showing us the posterior cruciate ligament. If you note in this picture on the left, the ACL has been cut. Notice like right here, this is where the anterior cruciate ligament normally attaches, and it would come up like this. Like that's where the ACL normally is, but it's been taken off so you can see the PCL. Even when the ACL is there, like even when this is like this, you can still see part of the PCL poking out over here. It's just once we take it out, you can see the posterior cruciate ligament a little bit better. You can see the two bundles here and here, the anterolateral bundle and the posteromedial bundle. Anterolateral because it is more anterior and more lateral. If you look at the knee, always keep in mind if you're trying to figure out medial and lateral, the fibula is lateral, right? The tibia is medial. So this one is a little bit more lateral and it's in front of the other one. So anterolateral bundle. Posteromedial bundle is more towards the medial side, right? More towards this side, and it's in back. This picture on the right is showing us the back of the knee. You can see this is the posterior-medial bundle, right? And then this right here is, you can see, just part of the anterolateral bundle. The other, you can see little kind of small little ligaments that stretch across, like right here, and then in the front you can see this, like right here, this little guy. This is the anterior meniscofemoral ligament, and in the back is the posterior meniscofemoral ligament. These go from the meniscus up to the femur. So you can see here, this is the lateral meniscus, the little piece of cartilage. This ligament's going from that lateral meniscus up to the femur in the back of the knee. And then here in the front, you can see here attaching to the meniscus and then going up to the femur in the front of the knee. Speaking of, so there is a medial meniscus and a lateral meniscus in the knee. Tears to either of these cartilage pads are very common. Here, looking at the knee, you can see the lateral meniscus and the medial meniscus. The lateral meniscus is on the lateral side, so the side of the fibula, but it doesn't touch the fibula. Both the lateral meniscus and the medial meniscus are between the femur and the tibia. It's just between the lateral condyle of the femur and the lateral condyle of the tibia. And then the medial condyle of the femur and the medial condyle of the tibia. There's a cartilage pad between both of those. Again, the cartilage pad is there. One, there's padding because we do need some cushioning and shock absorption between them, between the bones, but it also provides a smooth surface. So there's a nice smooth surface for the joint movement to occur. Meniscal tears interrupt that smooth movement. So if there's any sort of a tear to the meniscus, it impairs the smooth motion of the knee, and the knee can tend to lock up during movement, get stuck in a certain position, or patients can, bend the leg and kind of straighten it, but they can't completely straighten it. They can't lock the knee because there's some sort of a rough surface or some sort of a torn area on that meniscus. We can have acute meniscal tears. These happen most often during twisting injuries of the knee. So, for example, you twist the knee and tear the ACL and also the meniscus. Again, they do commonly occur with ligament injury, so ligament injury along with a meniscal tear. There can also be chronic degenerative tears that occur in the ligaments. Acute tears are most common in athletes, but chronic degenerative tears are most common in older patients. And these can occur with minimal stress. It doesn't have to be a big football player who's tackled really hard while sprinting down the field. This can be just minimal stress, but because of all of the degeneration in the knee, they can be more prone to tears. We can classify meniscal tears in numerous different ways. They can be classified as partial or complex based on the size and depth of the tear. They can be classified as anterior, lateral, or posterior based on the position, as traumatic or degenerative, right, which we just mentioned, and then also by the shape and orientation. So, for example, like vertical tear or horizontal tear. Tears, typically what we do when we have meniscal tears, we can usually repair them with arthroscopic surgery. Where just small little holes are made in the knee, a camera is inserted into one of those holes, we can insert tools in the other holes, and there's a little tool that looks like a little shark mouth almost, but it works just like a file where it goes and it chews off the area that's been torn, and it just smooths it down. So it's almost like sanding a rough edge. If you've got a rough edge on wood and you just rub a sanding tool over it until it's smooth again. So when you do that, you take off a little bit of the wood, right? But you leave it smooth. That's what happens with the cartilage. When you sand it down like that or smooth it out like that, you take off a little bit of the cartilage, so it thins the cartilage out, but it makes it smooth again. And that's what we want. We want the cartilage to be smooth. Now, that does put the patient at an increased risk for developing osteoarthritis. These cartilage pads between the knee are important for preventing, irritation to the bones themselves. So the thinner that cartilage is, the more likely the patient is to at some point develop arthritis. So you don't want to go in there and just repair. And when repairing, we want to remove as little as possible. Now, that is typically more successful than trying to stitch up a tear, but we can stitch up a tear, especially if it's a lateral, like if the injury is, instead of being in more centrally in the meniscus, if the injury is like out on the very outside, if the tear goes through the very outside of the cartilage, then you don't want to shave it off, because if you shave this side out here, the meniscus is not flat anymore. You can't make it flat. Now it's at an angle like this, and we don't want that. So if the tears are the very outside, sometimes we will try and stitch it up, but that it has but that has a lower success rate because the cartilage is, for the most part, avascular. It does not repair well. So stitching something up does not guarantee that the sides are going to heal together nicely. So after, stitching up torn meniscus, it is important to go back and reevaluate to see if the procedure was successful or not. The last slide on here, guys, I made FYI. This was just pointing out the ankle joint. We did in lab, we did go through the bones of the foot, the ankle and the foot, and in the other lecture, we did talk a little bit about the foot in terms of like plantar fasciitis. But this is it. I was going to go through all of the individual ligaments and then like ankle sprains and fractures, but we ran out of time. This lecture had to cap at an hour, and we're pretty much there right now. And this is the last lecture before your next exam. So this is it. This slide will just be FYI. I do recommend that you guys read through this chapter, or this part of the chapter in the textbook, to at least familiarize yourself with things like ankle sprains and fractures, toe fractures, that kind of thing. And then, if you do that and you have any questions, go ahead and shoot me an email. But this will not be on the exam. Okay, at the knee is where we're going to stop the stuff to be on this lecture exam coming up. All right, thanks.